Hi everyone. My name is Jen. I'm an MD PhD student at UCSF. Today I'll tell you about work that I did as a graduate student with Dr. Lauren Frank. When I started in the Frank Lab, I was really struck by our capacity for abstraction, our ability to form these internal models of what goes on around us. And the work I'll tell you about today is aimed at understanding how the brain supports abstraction. To set the stage, I want to tell you a story. When I first moved to San Francisco, I discovered two restaurants that make tacos that I found I really enjoyed. So a typical experience I had was leaving my apartment in the evening, heading east towards Pomelo, where I'd pick up tacos and head home. And I made similar journeys to a different restaurant heading north to Nopalito. During these outings, I had an internal model of specific aspects of these journeys, like of the paths that I took and the locations of the restaurants. At the same time, I had a more general model of the steps involved in this task of picking up tacos for dinner. These kinds of internal models are often referred to as cognitive maps. And the question that I'm interested in is how these are represented in the brain at distinct levels of generality. Previous work has identified at least three areas that seem to represent these kinds of cognitive maps. This includes the hippocampus, as well as the medial prefrontal and orbitofrontal subregions of the prefrontal cortex. And moreover, when people have looked in all these areas, they've seen that various elements of experience are represented. So in the hippocampus, you find place cells, neurons that represent space by activating in select locations in an environment. But you can also find neurons that represent sequences of actions and more abstract quantities like progression through a task. And in the prefrontal cortical areas, you can find neurons representing these same variables. And so this raises the question, are there organizational principles that govern how representations of specific and generalized aspects of experience are distributed across these brain regions? To address this, we carried out large-scale recordings across these areas in rats as they performed a task that is kind of like picking up tacos for dinner. So the overall structure of this task involves traveling to reward wells in a maze, waiting a short time for a milk reward. We reward rats for making alternating visits to two outer wells from a home well. And this allows rats to experience this overall task structure across these distinct spatial and motor contexts provided by the different paths in the maze. We had rats perform this task with different home wells and across different mazes. And we recorded continuously over several days as rats learned the task, reacquired it across these contexts, and then after learning. Today, I'm just going to tell you about a set of findings that hold within each of these contexts in the well-learned state after learning. We were able to monitor several tens to a few hundred putative neurons in each brain region simultaneously. And the first thing we wanted to do was gain intuition for how activity is structured around the task in each of these brain regions, so the hippocampus, medial prefrontal cortex, and orbitofrontal cortex. To do this, we visualized activity using a dimensionality reduction technique called UMAP. We took 100 millisecond firing rate vectors from simultaneously recorded neurons in a brain region and embedded these in 3 dimensions. Similar neural activity appears in similar regions of these embeddings. Here we have embedded hippocampal activity, colored according to the path the rat was on. The red dot marks a point in time in this recording session, and the corresponding behavior of the rat is to the left, and the task phase is at the bottom. As the rat travels from the left well to the home well, we see an evolution of the neural activity through a particular part of this embedded space. During the entire recording session, the rat makes several passes down each of the 4 paths, and we can visualize how activity unfolds during these passes by coloring the neural state according to the fraction of a path the rat has traversed. And if we do this, we see consistent evolutions of activity across passes down each path. So together, these visuals suggest a primarily route-based code for the task in hippocampus, with stereotyped neural sequences unfolding along each of the 4 different paths. What do we see in the prefrontal cortex? we see a very different organization. Here we have embedded activity from medial prefrontal cortex during the same recording session. And now we see an organization primarily around the journey between any two reward wells, with activity unfolding in a similar way along each of the four paths. There also appears to be a sub-organization around actions, with activity evolving more similarly along paths requiring two left turns, and likewise along paths requiring two right turns. The OFC activity shows a similar organization around progress towards goals and actions. If we look closely, though, we also see a difference between MPFC and OFC in when activity unfolds reliably. Reliable activity appears as more concentrated regions of the embeddings. Towards the middle of paths, activity is more concentrated in the MPFC and more diffuse in OFC, whereas the opposite is seen as rats arrive to reward wells and into the delay period just after arrival. So these embeddings suggest to us a few organizational principles. First, we think we see distinct codes in hippocampus and prefrontal cortex, with hippocampus primarily mapping spatial routes, and the prefrontal cortical areas, the abstract progression to goals and actions required to reach them. We also see what looks like a division of labor within the prefrontal cortex, with MPFC and OFC trading off to provide consistent representations of task progression at distinct behavioral periods. These embeddings were just tools for hypothesis generation, and to test these, we performed single-cell and population-level analyses. Today, I'll tell you about some analyses we did to test the second hypothesis. So here we want to quantify the consistency of neural activity during the task. We consider the neural state space where each axis corresponds to the firing rate of a recorded neuron in a brain area. If activity unfolds in a consistent manner across trials, then we should see something like this. Whereas the rat travels down one of the paths, activity will unfold in a particular way. And then if the rat makes another pass down that same path on a different trial, activity will unfold in a similar manner. We devised metrics to quantify the consistency of the placement of neural states, or in other words, their geometry, as well as the changes in neural states, or in other words, their dynamics. What do we see in terms of the geometry? Here we have a metric where higher values indicate more consistent geometry. We're looking at this along the extent of paths. MPFC values are in green, and OFC values are in blue. And consistent with our hypothesis, we see higher values in MPFC indicating relatively more reliable representations of running along the path to a well in the MPFC. If we look now at the delay period, we see the opposite, where now OFC shows more reliable representations. And so MPFC and OFC are trading off to provide consistent representations of progress through the task during these different behavioral phases. So this is data from one subject. We see similar findings in our other two animals, and also when looking at population dynamics. So to summarize, we see evidence for a region-specific code for specific and generalized representations across these areas. This manifests in at least two ways. We see distinct cognitive maps in hippocampus versus the prefrontal cortical areas, with hippocampus primarily mapping spatial routes and cortical areas, the abstract progression towards goals and actions required to reach them. We also see a difference between MPFC and OFC and when these representations are reliable. So with that, I want to thank my thesis advisor, Dr. Lauren Frank, the rest of the Frank Lab. These are links to our preprint and code. And a huge thank you to program leadership for this opportunity to rotate, to all the residents and faculty for your teaching and mentorship. This was an incredible month, and I learned so much. And thanks to my fellow co-sub-Is as well.
Yes. Okay. So hi, my name's Logan. I'm a fourth year medical student at UT Austin. I'll be talking to you about the research I did during my built-in third year of med school research year that I went up to MGH under the mentorship of Dr. Dan Cahill. It is investigating modulators of radiation sensitivity in IDH mutant astrocytomas. So I'm sure this group especially is quite familiar with the adult type diffuse glioma, but just as a refresher, given the 2021 WHO classification changes, where instead of pathologic, we tend to rely on molecular markers. In the adult type diffuse glioma type, we tend to divide based on IDH status between mutant and wild type. As we all know, wild type is the glioblastoma that we often see, and that has its own very robust body of literature. What I'm talking about today is the IDH mutant astrocytoma with 1p19q intact. So in this specific tumor type, this is the most common primary cancer of young adults under the age of 45. And the typical treatment paradigm is usually some combination of surgery, radiation therapy, and chemotherapy. CDKN2A is cyclin-dependent kinase inhibitor gene 2A. It encodes P16 and P14 and serves as a tumor suppressor. So as you can see from this figure, in other words, it essentially serves as a brake for the cell cycle. And when you take the brake off, you endure rapid cell cycling and tumor progression. And 35% of this tumor type, the IDH mutant astrocytomas, have this CDKN2A mutation. And so what we know is that the CDKN2A deletion is almost always seen after radiation therapy in IDH mutant astrocytomas. We also know that this mutation is associated with a worse prognosis for this tumor type. So here's the current model of what we know. So radiation therapy is the current treatment recommendation. Although it effectively reduces the tumor size, we see the emergence of the CDKN2A deletion. And once tumors have this deletion, they have increased tumorigenicity and a worse prognosis. So this leads us to two alternatives exploring the relationship between radiation therapy and CDKN2A mutation. Either in this tumor type, no cells have the deletion and radiation therapy can somehow induce the CDKN2A mutation in the tumor cells, or there's a subset of CDKN2A deleted cells, and only those cells mutate and survive to progression. So my question was, does CDKN2A deletion, which emerges in the setting of radiation therapy, confer resistance to radiation therapy? And to test this, we used a patient-derived IDH mutant astrocytoma cell line, MGG152, and then a version of the cell with the CDKN2A deletion. And so on day one, I plated the cells. Or on day 0, I plated the cells. On day 1, I administered radiation therapy. And on day 5, I did a CTGA analysis to compare differences in cell proliferation between groups. So what I found is that CDKN2A deletion does not confer radioresistance to radiation therapy in this model. So I'm going to draw your attention to the graph on the left. So we see the CDKN2A intact in blue and the deleted in purple. And you can see the cell viability, so how much radiation was able to decrease the number of cells, is no different between groups. And even we see a decrease, a heightened sensitivity in the CDKN2A deleted line. And this was statistically significant at biologically relevant radiation doses, which according to our radiation oncology colleagues tend to be around 1, 2, and 5 gray in the laboratory setting. Mechanistically, it's unclear why this is occurring. So one thing I wanted to explore is if the radiation therapy is impacting the cell cycle differently, given the CDKN2A mutation impacts cell cycling. So to test this, I conducted flow cytometry. So in a similar setup as my experiments before, I took the CDKN2A intact and deleted cell lines. I radiated at 24 hours at varying doses. And then day 2, I stained for cell cycle analysis. And to do this, I used 2 different stains, EDU and PI. EDU stains, it intercalates into the DNA, so it can tell us whether or not cells are in S phase, and PI can tell us copy number. So the combination of these 2 stains can tell us if a cell is in G1, S, or G2. And the proportion of these cell cycle profiles can kind of tell us what different interventions, what type of effect that they're having, and how it might be different in different experimental conditions. So what I found is that radiation therapy induces G2 arrest in MGG152's the intact model in a dose-dependent manner. So I'm going to draw your attention to the G2 column on the right. As you can see, with increasing dose of radiation, we see this steady increase in the proportion of cells arrested in G2. And what I found is that this arrest is further increased in the CDKN2A deleted line. So if you look at the graph on the right, we can see the G2 proportion increases with increasing radiation doses, but this also starts at a higher proportion than the CDKN2A intact and further increases. And this was statistically significant as well. So how might this increased G2 arrest indicate a mechanism for heightened sensitivity? We have some hypotheses. Perhaps there's more poor mitotic resolution. Maybe it's just the slower progression through the cell cycle is giving cells more of an ability to be damaged by radiation. Perhaps there's reduced DNA repair capacity. So in summary, does CDKN2A deletion confer radio resistance was my original hypothesis. So what I found is that in the CDKN2A deleted cells, they're actually not radio resistant. In fact, they're more radiosensitive. And a mechanism possibly to explain this is that there's more dose-dependent G2 arrest. So these initial findings were presented as a poster at the American Society of Clinical Oncology, and we're currently preparing a manuscript. In terms of future directions, we want to see if these findings replicate in actual patient populations. So we're combining CDKN2A deleted patients and seeing the relationship between radiation therapy, the timing of the radiation therapy, and how their tumors have progressed. And then we're also trying combination therapy with vorasidenib, the IDH 1 and 2 inhibitor, with radiation therapy, and have some promising preclinical data for these combination therapies. Thank you so much, and I'll take any questions.
Thank you. That was great, Logan. Questions for Logan? Anything?
Dr. Emerson has a question.
Dr. Emerson, I see your hand up.
Yeah, great talk, Logan. I'm wondering if you have ideas about how you would get at your first question, which I think is important, is whether the CDKN2A loss is something induced or selected for.
Yes, that is a great question. And when I originally started this project, full disclosure, we anticipated these cells to be radio resistant. And so when we got the results that they were actually more radiosensitive, favoring the former hypothesis that maybe there's something about the radiation therapy that's inducing it, that kind of surprised us. So I think our first way to go about assessing this relationship is looking at the patient populations and seeing if there's a relationship in those who have already been treated by radiation therapy and the emergence of the CDKN2A deletion, to see if it warrants a further study in vivo or in vitro of actually seeing the progression of this mutation taking place. In terms of an actual like cellular or animal model, I think it'd be really difficult to radiate and then test for the exact CDKN2A mutation. So I think, yeah, I think there's room for exploration there on the best way to test that type of question.
All right, good morning, everyone. Thanks for having me. I'll be talking about my experience at my institution regarding labyrinthectomy, improving dizziness in patients with vestibular schwannoma. So to start, some key considerations. Vestibular schwannomas, although histologically benign, often cause neurological and functional impairments that diminish well-being due to disease progression. And the clinical outcomes that are usually measured for these cases are facial nerve function, hearing preservation, tumor recurrence. But now we're recognizing more and more that healthcare priorities may differ from patient values. And there is a gross increase in wanting to incorporate patient-reported outcomes to comprehensively assess the impacts of treatment. With vestibular schwannoma specifically, among the many symptoms and challenges associated with them, dizziness is actually one of the most prevalent and debilitating for patients. And specifically, it has one of the greatest long-term quality of life impacts by the Vestibular Schwannoma Quality of Life Index developed at Mayo. But despite the prevalence and severity of dizziness, there's little data on what surgical factors affect postoperative dizziness after resection of vestibular schwannoma. So I won't go into too much detail on surgical approaches because I know the audience generally knows, but just as a little refresher, there's mainly 3 types of approaches for vestibular schwannoma resection. There's the translabyrinthine approach highlighted here, which precludes the possibility of hearing preservation as you go through the internal auditory canal and drill through the bony labyrinth and inherently cause hearing loss during this procedure. And then there is the retrosigmoid approach, also known as the suboccipital approach, as well as the middle fossa approach. And then both of these approaches are generally hearing preserving or give the possibility to preserve hearing because the vestibular nerve is sectioned at its division of origin. So I was interested in knowing, after looking into the literature, it seemed that both isolated vestibular neurectomy and labyrinthectomy were documented in otology literature as effective treatments for idiopathic vertigo. So building on this foundation, our objective was to investigate whether surgical approach and or vestibular nerve sectioning were associated with postoperative dizziness. We focused on the term dizziness as it captures all complaints generally related to vestibular dysfunction and to focus primarily on patient-reported symptoms. To our knowledge, the study represents the largest and most comprehensive analysis to date, specifically addressing the impact of surgical technique on dizziness outcomes in these patients. So regarding methods, this was a retrospective study of 333 patients who underwent resection at my institution. Study variables were diverse, but included collecting the surgical approach used, facial nerve function, hearing status, reported subjective dizziness by patients, and vestibular nerve sectioning. Our primary endpoint was dizziness outcomes at 6 months. And the way we kind of found this out was we looked at descriptions of dizziness recorded through a systematic assessment of the patient chart and documented the patient's subjective experience of dizziness at their pre-op, discharge, 6 month, and 1 year post-op intervals. All dizziness was subsequently categorized as absent, mild, moderate, or severe. In comparison to preoperative dizziness was further classified as absent, improved, stable, or worse. Facial nerve and hearing outcomes at 6 months were our secondary endpoints. Facial nerve function was evaluated with the House-Brackman scale, and hearing outcomes were based on audiological reports in following the guidelines set forth by the American Academy of Otolaryngology. Generally, we chose 6 months as the primary endpoint as it optimized subject loss to follow-up, but was more than just what happened in the immediate post-operative setting. And from a statistical standpoint, we used contingency tables to compare multivariate frequencies for dizziness, facial nerve, and hearing outcomes. Statistical significance was assessed then with the Fisher's exact test for relationships in the contingency tables. And predictors of post-op dizziness, facial nerve, and hearing outcomes were identified through multivariate generalized logistic regressions. And I did my data analysis in R and GraphPad Prism software. So a little bit just about the patient and tumor characteristics. I mainly wanted to highlight here that the majority of patients at our institution underwent a translabyrinthine approach. That was 266 patients, while only 67 had resection with hearing preservation approaches. And so starting off with some results here, reports of dizziness were first kind of displayed on line graphs. And so on the left here, this line graph illustrates the percentage of patients reporting dizziness over time stratified by surgical approach. And you can see a clear difference in dizziness rates between the two approaches. On the right side here, this graph is comparing the percentage of patients reporting dizziness in non-labyrinthectomy patients, specifically being further divided into groups, whether or not the vestibular nerve was selectively sectioned. And as there was no significant difference in dizziness rates between these groups, vestibular nerve section was not included in our further analyses. So looking further into binary reports of dizziness, the Fisher exact test revealed no significant difference in binary outcome of dizziness based on preoperative reports and surgical approach, as you can see here. However, at discharge, patients who underwent a labyrinthectomy reported a lower incidence of dizziness compared to those who did not. And this association persisted at the 6 month and 1 year follow-up intervals. For categorical comparative descriptors, this relationship remains significant at discharge, 6 month follow-up, and 1 year follow-up. A multivariate logistic regression model was then built, including all variables thought to contribute to possible dizziness at 6 months, including age, sex, tumor size, etc. And as you can see, our numbers show that surgical approach was the only factor that reached statistical significance here. Our approach for exploring the effect of surgical approach on hearing and facial nerve outcomes were like that of dizziness. And so for hearing outcomes, we specifically compared non-labyrinthectomy patients who underwent vestibular nerve sectioning versus those that did not. And as you can see here, there was no significant difference in hearing class at the preoperative time point or at the 6-month follow-up. Similarly to hearing, facial nerve outcome also showed no significant difference based on surgical approach. And so a few discussion points here. So there are generally few studies on the impact of surgical approach affecting dizziness in vestibular schwannoma patients. In 2007, there was a study by Godfrey et al. And they reported significant reduction in rotary vertigo in about 18 vestibular schwannoma patients who underwent a translab approach. And they suggested labyrinthectomy can improve dizziness. In 2017, a study by Sami et al. Showed improvement in about 19 patients with vestibular dysfunction using the retrosigmoid approach. However, neither study really used a comparison group. Both studies were included in a 2020 systematic review by Oha et al., which concluded that surgery in general can improve dizziness in vestibular schwannoma patients with severe vestibular dysfunction. I bring that up because our data reveals that despite dizziness being reported similarly between labyrinthectomy and non-labyrinthectomy cases preoperatively, we saw a steady reduction in reported dizziness and increased improvement over time in labyrinthectomy patients. And in non-labyrinthectomy patients, we see that dizziness worsens in the immediate post-op period and plateaus for the 1 year that we observed. And we found that our results were interesting because despite the apparent parity of vestibular neurectomy to labyrinthectomy in otology literature, we did not find vestibular nerve sectioning to have an effect on postoperative dizziness, or at least one of significance. One possible explanation could be due to the fact that in these hearing preservation approaches, we take care to only remove the nerve of origin to preserve all potential contribution to the cochlear nerve, whereas in otology, they often section both divisions of the vestibular nerve. So in our case, the remaining division that we leave behind may contribute to postoperative dizziness. And that's not the equation in the case of labyrinthectomy, where we destroy the end organ. And given our results, we believe that in carefully selected patients, data suggests that a translabyrinth approach for patients with severe dizziness could be useful and should be considered in patient counseling and overall treatment guidelines. And so to conclude, just as I have kind of gone through, dizziness was improved with labyrinthectomy unaffected by selective vestibular nerve sectioning. We hope the study influences others to incorporate patient-centered outcomes like these to improve overall counseling, treatment planning, and surgical decision-making. With that, I'm happy to take any questions, and I want to thank everyone. I've had a wonderful month here, and I appreciate everyone's mentorship, teaching, learning, and the guidance I've received. Thank you.
Thank you, Pooja. Any questions for Pooja?
Hi, Pooja, Dr. Ellenbogen, Jake Rusnak. I just wanted to say to all the students, really enjoyed all of your talks. A lot of hard work goes into it, so nice job. For Pooja, you know, it's a very interesting study. Dizziness is certainly one of the symptoms that, you know, patients are concerned about after surgery, especially in the immediate aftermath of surgery, but also in long-term lasting up to a year. I'm kind of have two questions. The first is, did you stratify for tumor size at all? Because size, you know, really does influence the approach that you take, and also can influence a lot of those secondary outcomes of facial nerve preservation and hearing preservation.
Yes, we did, and That I didn't have time to include everything in this talk, of course, but we did look at extent of resection, and of course, the translabyrinthine approach is generally, because of its large exposures, generally used for larger tumors, but the retrosig and middle fossa approach, preferred for a lot of reasons for the smaller tumors. So we did stratify, and I can send you the numbers too. We found a middle group of moderately sized tumors that overlap between the two. And we actually did stratify by size, but I don't remember the numbers off the top of my head, but I can send you those.
Okay, perfect. Yeah, thanks so much. Dr. Shaker has his hand up too, so I'll skip my second question.
I presume that all the patients operate by translabyrinthine approach in this case, in these patients, hearing preservation was not a goal at all. So, because if you're attempting to preserve hearing, you won't be using a translab approach. So again, then the question of tumor size comes into play. Are they comparable tumors in which you're doing retrosigmoid approach and translab approach? That being assumed to be the case, it's quite surprising that vestibular nerve section did not improve the dizziness, but labyrinthectomy did, and that is very difficult to explain because the dizziness is mediated through the vestibular nerve. So it seems that to some extent your study has a bias because more than 2/3 of the patients have been operated by translab approach, and then only 67 patients operated by either retrosigmoid or middle fossa approach. So perhaps experience level may be a factor here as well.
Thanks,
Yes,
Shane.
that's very true. And we were hoping that our multivariate analysis would somewhat offset or account for the fact that there was a discrepancy in how many cases underwent a translabyrinthine approach versus the non-labyrinthectomy cases, and understanding that, there's institutional preferences and our institution seems to prefer the translabyrinthine approach. That's kind of why in the future we would like to, kind of expand the study to include multiple institutions and possibly further mitigate this and get a more general variety of approaches to further classify how dizziness can be affected by them.